Here we go.
Well, thank you so much, Zach, for reminding. And I'm sorry, friends, I didn't record earlier and we missed the introduction from Victoria and Sam. But yes, again, thank you so much for joining everyone. And it's first time Victoria is presenting the case, so we are thankful to her and hopefully we will learn a lot from her case. And I'm joined by Yusuf today, who is running a little bit late. He will join us soon and he will be co-discussing along with me. So let's get started, Victoria, whenever you are ready, and maybe I can discuss the first study part.
Yeah, let's do it. Okay. So to give you some context, I did see this patient back in September of 2023. So some of the dates that I am going to give you, just, keep in mind that I saw him in 2023. So we can start with the chief complaint, which is arthralgias and fevers. And starting right with the HPI, he is a 27-year-old male. He came to the ER complaining of fevers and rashes. He did have about 4 to 5 episodes of fever, rash, facial swelling. He said it would last about a few days and then it would just resolve. Most recently, October of 2022, which was the year before I saw him, he began having bilateral shoulder pain extending to his elbows. His hands included the MCPs, PIPs, ZIPs. He was treated for Lyme disease at that time. And then in March of 2023, so a few months later, he came back to the ED. He had fevers, continuous like clockwork. He said it would start around like 5 p.m. Rashes also on all extremities that would then disappear. And at that time, he was treated for Still's disease with 80 milligrams of prednisone tapered. At that time, he was also started on methotrexate and Ilaris, which is a biologic injection. He then was following a rheumatologist and he had blood work done. And I remember this because he said, my doctor called me on Labor Day, which no one works on Labor Day, but he called him on Labor Day and said, you have to go to the ER like right now. Your labs are not okay right now. They just came back. And so he went to the ER. He was still at that time complaining of clockwork fevers and just feeling really tired. And to give you some context on what these labs were that caused the doctor to give him a call, he had transaminitis, so his AST was 727, ALT was 808, LDH was elevated at 2,836, his ferritin was extremely high, over 20,000. He was CMV positive and he was thrombocytopenic. His platelets were 63,000. So these were some of the labs that we got when I first saw him. But these were ER labs when he was told by his doctor to come into the ER. So I'm going to take a quick little pause here before I move on to other information and let you guys discuss.
Perfect. Thank you so much, Victoria. And let me clarify two things that this patient has been having fever, rash, and arthralgias. And do they resolve in between? Because you said episodic, right?
Yes, it is episodic. So they do happen around the evening time. These rashes just sort of come up and then in the morning they just go away.
Right. And do we know where the rash was located?
Based on my notes that I have here, he said it was on his extremities. So it's not really in his trunk, it's more sort of his arms and his legs.
Right. So like everything started in October and he was getting these episodes. And then after a few
Yeah.
episodes, he was diagnosed with Stills, right? I guess.
First, they thought he had Lyme disease, so he was
Okay.
treated for that. Then,
Uh-huh.
that didn't work out, and then he was diagnosed with Still's disease, and he had treatment for that. But again, he was being seen by the rheumatologist, and I guess they still hadn't really reached a actual diagnosis yet.
Right. And the arthralgia, are they still present or not?
When I saw him, yes, the arthralgias, the fevers, and the rashes were still present.
Okay, and the last question, this Stellara is like, is it IL-17? Like, is it secukinumab? I just wanted to make sure that we got the correct biologic.
Yeah, it's called Ilaris. Let me
Sorry about that.
just do a quick check. I'm not sure what exactly it targets. It's an IL-1 beta.
Okay,
It
IL-1 beta. All right.
neutralizes it, basically.
All
Yeah.
right. All right, perfect. All right. No, thank you so much, Victoria. Like, I
Yeah,
have never seen such like a thrilling start to the case
I
ever.
know.
Like,
I know. I wanted to give you guys like a lot of context because then it gets a little bit more crazy. Not crazy, but anyway, it gets more
sure.
interesting. So,
No. Thank you so much, Victoria. So, friends, like, first I will take a first step and then I will ask Yusuf to chime in. So, looks like we are dealing with a young gentleman who has been having a constellation of symptoms in the episodic form since last 1 year. And the three classic symptoms we are dealing with right now are the fevers, arthralgias, and the rash. We haven't characterized the pattern of arthralgia yet, but from the description, looks like it is at least polyarthralgia or oligoarthralgia. Do we have polyarthritis or not? It's hard to say. We will get the imaging down the line to see if there is joint destruction or is it just migratory pain. Regarding the rash, we will see in the examination what kind of rash it is. Like, is it urticarial rash? Is it erythematous rash? Do we have mucosal involvement or not? Do we have conjunctival involvement or not? So all these variations in the rash can guide us in terms of differentials. But so far the data we have looks like that this person was diagnosed with Still's disease at some point in time. And it makes sense, right? Because we know that Still's disease is one of those autoinflammatory disorder which tends to present with episodic flares and can end up causing fevers, arthralgia, and classic like rash, like as described as salmon rash, right? And I'm sure that when they diagnosed the patient with Still's disease, they must have excluded some other common conditions, because when you diagnose a Still's disease by Yamaguchi criteria, one of the criteria is that it has to be diagnosed of exclusion and you have to rule out infections, malignancies, and other autoimmune diseases. So it would be highly unlikely that this person, let's say, has a lupus, because like ANA negativity has to be one of the criteria to diagnose the Stills. And not just this patient was diagnosed with Stills, but was placed on one of the biologics, which itself speaks, right, that you must have done a thorough workup before giving someone biologics. So at least at this point in time, I'm thinking that some of the common infections and some of the common autoimmune diseases are already lower on my differentials based on how patient is presenting. Now, one key aspect which I wanted to highlight regarding the diagnosis of Still's was that in general, although Still's is an autoinflammatory disorder and can present with episodic and recurrent presentations, in general, it is a monophasic disorder as compared to other autoinflammatory disorders, like let's say familiar Mediterranean fever, which presents with like, every month it can keep on presenting again and again despite treatment. But Still's disease in most of the people do not come again. So that is one of the red flags, that is it truly a Still's disease or something more than that? And as you could imagine, that Still's disease, we still don't know the gene which classically causes Still's disease. So there are so many undiagnosed, unclassified autoinflammatory disorders which might be initially diagnosed as Still's disease based on some of the criteria, but which will eventually not fit in the classic illness script. And that's how we will do like whole exome sequencing, and you may find a new gene for it, right? So that's the one caveat, that recurrence again and again argues against Still's disease. The second important aspect which we have to deal with right now is that despite being on supposedly a good biologic for any autoinflammatory disorder, which is IL-1, because almost all the autoinflammatory disorders are driven by IL-1 to some extent. So giving anakinra or canakinumab to someone with unclassified autoinflammatory disorders is a wise decision, because it might control the symptoms at least for a while. But now the patient is presenting again with the same recurrence of symptoms, and the blood work is showing that we have deranged liver function and some degree of cytopenias. So, and ferritin is also very high. So whenever we see the combination of high ferritin and cytopenias, you are going into the category of HLH, right? And we know that HLH is a big term, which stands for hemophagocytic lymphohistiocytosis or macrophage activation syndrome. And there are literally like hundreds of triggers for HLH and MAS. But one of the common triggers is autoinflammatory disorder and autoimmune disorders, right? So now we have to start thinking that, is this person progressing into the territory of HLH, MAS, and do we need quick help from the rheumatologist to dampen the inflammation before we can figure out the underlying cause? Because if we don't dampen the inflammation in the timely manner, patient can suffer the end organ damage from HLH and it could be catastrophic, right? Once we have calmed down the HLH and once we pass through the history more clearly, that when these episodes came, what is the rash, maybe we can dig deep into the kind of underlying autoinflammatory disorder we are dealing with. What do you think, Yusuf?
Yeah, thank you, Kirtan, and thank you, Victoria. I think if we pause and put a label on the background, patient's background is a diagnosis of Still's disease. And the problem we're trying to solve right now is fevers and elevated liver enzymes. So like Kirtan mentioned, it's a very rich background. What does that tell us? I think one thing it tells us is that could this patient have like persistent Still's disease or a progression, like Kirtan was alluding to, like HLH? Or are they having a complication of the treatment? If we hear here that the patient received steroids, methotrexate, and interleukin inhibitors, and the types of infections that you're predisposed to, it all depends on the type of immunosuppression. With interleukin inhibitors, I would worry about like intracellular organisms. And so I'm keeping an eye to think of like, is this a complication of Still's disease, or is this like a infection that we need to think of? And I think it's very fair to pause and say, is this actually Still's disease, or are we missing anything, like Kirtan was alluding to? And it sounds like some time has already passed since the original diagnosis. And usually the mimics you want to rule out are chronic infections like histoplasmosis for infection, for example, or lupus, and we'll keep an eye out for those as well. So I think I would say that I'm nervous. I'm looking for any signs of infection, and keeping in mind that if someone is immune compromised, their symptoms might not be as flagrant or as strong. You have to take any subtle signal and run with it. And I'll keep an eye out for that and looking for still these mimics. And I think this is a case where I would want to call the consultants very early on, ask about exposure history. Are they going hiking? Are they have a pet tick at home, etc. So can't wait to hear more, Victoria.
These are all really great differentials. Let's see if we can narrow it down a little bit. So the next aliquot, I'll start with social history, which is he has never smoked, never used illicit drug use, doesn't drink alcohol. His brothers and sisters are healthy for family history. He did state his father has a heart condition, unsure of what it is. For his allergies, azithromycin, he only gets some swelling. And then for the review system, so just again to give you some context, he came to the ED September 3rd. I didn't see him until I believe it was September 10, where they had started treatment already. So just keep that in mind that the review system and physical exam might be anyway, I'll just read it out. So for the review systems, nothing really remarkable stood out. Just to go over the systems, he had no chills, no weakness, no joint stiffness or pain, no photosensitivity, no eye dryness. For respirations, no short of breath. He wasn't complaining of any abdominal pain, no chest pain, nothing like that. Moving on to his vitals, they were stable when I saw him. He didn't have a fever. His temperature was 98.5. His heart rate was 80. His blood pressure was 110/65. So very stable. When I saw him, he was just resting in the stretcher, very comfortable. So moving on to the physical exam, as I mentioned, lying in bed and no acute distress. His eyes were anicteric, pupils were equal, round, and reactive to light. Mucous membranes were moist. No lymphadenopathy appreciated. His chest, for his lungs, they were clear bilaterally. His heart, again, S1, S2 appreciated. No murmurs. Nothing really standing out to me. The abdomen was soft, non-tender, non-distended. For MSK, we did move all of his extremities, and he did have active range of motion on all four extremities, no pain elicited. The only thing that I would mention is I did see he had mild urticaria on both of his cheeks, sort of like just sparing the nose, just really more just on his cheeks. He didn't state that it was itchy or anything, but that's what I saw on physical exam. Otherwise, physical exam was pretty unremarkable. I can pause here before I move on to the labs and the imaging.
Yeah, that sounds good. And Kirtan, if you want, I can talk about possible infections we can think of, and you can talk about complications of autoimmune disease. How does that sound? Sounds good. So I think if I pause here right now and ask you, do you think this patient's blood cultures will be positive? Would you vote yes or no? Because I think my vote would be on no, because it's more like subacute. It's not like an acute presentation. It's someone who has relapsing fevers. And if somebody has relapsing fevers and the blood culture is negative, then where can it hide? So one, there are places that we can that the infections can hide that doesn't grow in culture. For example, you can consider fungal organisms. These organisms, usually you want specific antigen tests for. You would look for signs for them, for subtle signs. For example, for blastomycosis, you might look for a rash. For histo, you might look for like lung lesions, etc. That's one thing. Other infections you might consider are like micro-infections in the blood. So this includes like Brucella, Bartonella, Coxiella. These are, we don't grow these organisms routinely on cultures, but you would need to send the specific serologies and testing for those. And the third one is the smear. So this patient already had a tick-borne infection. Could they have another tick-borne infection in the past? So I think these are the big areas I want to look at. And while I'm doing like a general screening, I want to try to look for like any signal that can point me towards one more than the other. So we do hear about the thrombocytopenia, the elevated liver enzymes, which is if you all have not seen this before, I think you should. There's a schema that we call the doxy deficiency schema. It's basically a schema for all the arboviral infections, but it's usually infections that cause you to have thrombocytopenia, sometimes leukopenia or lymphopenia with elevated liver enzymes. And if this patient did not have this very rich background, it would automatically pull the schema. But because this patient has this rich background, it maybe confounds the picture. So it may be hard to know what's causing what. But I think that would be high yield as well. It's like, these infections can hide. I'm not going to detect them on culture, and I have to specifically think of them to test for them. So I would pull up the doxy deficiency schema and consider things like Ehrlichia, Babesia, malaria, and then arboviral infections. What are you thinking, Kirtan?
No, thank you so much, Yusuf, for highlighting all those very relevant and appropriate points that when you have liver involvement and cytopenias, you have to prioritize certain zoonotic infections, and most of them are intracellular. And as you pointed out, based on the immunosuppression, they might be relevant because we know that maybe you had some underlying condition which we haven't figured out yet, but because of the immunosuppression, now you have an infection which is riding along with you, and maybe that ended up causing some complication. And we know that any intracellular organism can also end up triggering HLH. So like all these tick-borne diseases, viruses, like let's say EBV, CMV, are known to trigger HLH as well, right? So of course we should keep our antenna high for those infections. We don't want to miss an infection while we keep on giving steroids. Patient might not make it to the end if we don't consider infections, right? So that's first point. Second point, I wanted to clarify from Victoria that this rash which we are seeing on this presentation, based on the notes, is it the same kind of rash which patient has had in the past?
I wish I could remember. I'm not sure. I'm
That's okay.
sorry, I'm not
Yeah,
sure.
but at least as of now, the rash is only on the face, right? And no
Exactly.
oral, right? Okay, no oral cavity, no eyes, no palms, soles, nothing,
No
right?
uveitis, no ulcers. No, the
Okay.
only positive thing really was just this rash. That's it.
Right. Perfect. All right. Thank you. So, friend, like it's important to clarify what we are dealing with because it looks like it's a complex case, right? That the diagnosis which we are going to have will likely be unusual. And for that, we need as much data as possible. And since now we are in the category of non-infectious causes, because Yusuf highlighted all of them, right? So what are some autoinflammatory conditions which can present with such presentation? So just like a quick primer, that autoinflammatory disorders basically mean that you have defect in your innate immune system, not in your adaptive immune system. Because the classic autoimmune diseases that we know of, like SLE, rheumatoid arthritis, are defects in your B cells and T cells, and that's why you end up getting autoantibodies which cause the damage. And usually they are continuous. Like you can have some flares in between, but the damage will be continuous. In contrast, when we deal with autoinflammatory disorders, you have problem with your innate immune system, which means neutrophils, macrophages, monocytes, and the intracellular pathways, like let's say inflammasome and nuclear factor kappa beta, all the different pathways. And the reason why it is important to consider them is because they classically present in the cyclical manner. So they might be presenting every other week, every month, or sometimes every other year. And depending on how frequently they present and what other symptoms they have, you can narrow down that what complications are we dealing with. So in our case, looks like that at least patient has been having the flares every few months, and every time patient has fever, rash, and arthralgia. So far, the review of system, we haven't heard anything of the GI system. There are some autoinflammatory disorders which can present with colitis, diarrhea, nausea, vomiting, which we don't have. There are some autoinflammatory disorders which presents with ILD and progressive dyspnea. We don't have any signal of ILD yet. Patient is saturating well, lungs were clear to auscultation. And of course, down the line, we will see if something comes up in imaging. So far, the pointers which we have is that the rash which is present is urticarial in nature. Now, we don't know how was the rash before, but if you think about it, urticaria on the face itself is a little bit unusual, right? It's something which is common if you have some allergies, like let's say allergy to food products, or maybe you got bitten by any insect or any allergy to medications. And from the history, looks like none of it is implicated. Patient doesn't have any classic allergies. Azithromycin was there, but in the past, not now. So question becomes that what kind of systemic disorders can cause urticaria and can also cause arthralgias, right? So this is of course a very niche topic, right? Very rare disorders will usually do it. But if we go systematically, then one disorder is that can this person have systemic mastocytosis, right? So we know that mast cells are the reservoirs of like histamine, bradykinin, and other secretions in the body. And if there are too many mast cells circulating in your body, then they can end up causing these episodic allergic-like symptoms, anaphylaxis-like symptoms, right? And there are different forms of mastocytosis ranging from like systemic mastocytosis to indolent mastocytosis to organ-limited mastocytosis, right? But one of the key caveats is that usually these people would tend to get episodic symptoms. They maybe there are triggers, maybe there are no triggers, but something which is unusual for mastocytosis in our case would be the arthralgias and fevers, which is not classically seen. So we would definitely get the serum tryptase levels to make further progress, but right now I'm keeping them lower on my differential. The second important disorder is that can this person have one of the rare autoinflammatory disorders known as the Schnitzler syndrome? It's one of those disorders, Schnitzler syndrome, which ends up with arthralgias, bone pain, fever, and urticarial vasculitis. And the way you figure this out is you get the bone scan and you will find that the diaphysis of your long bones would be sclerotic in nature. And that's how you figure out this rare disorder. Once we have moved past this, now even rarer disorders comes that what autoinflammatory disorders comes with urticaria. So one important category which I need to mention, given the possibility of HLH going on, is something known as NLRP3 mediated disorders. So NLRP3 is one of the inflammasome, which there are three disorders which falls under that domain. One of them is like Muckle-Wells syndrome or so-called familial cold autoinflammatory syndrome. So as the name itself suggests that these people may have cold, which can trigger urticaria, or may not have cold as well. And eventually, they will end up getting the systemic symptoms like bone involvement, arthralgias, fevers, and they will end up causing HLH as well. It is very unusual that we discuss such fancy things in VMR so early on, but it's just that the case is so complex already that there are no other common things left to discuss. So in my mind, what I would think is I would still go back in the chart, trying to characterize this rash better, see if this HLH has happened before also, because if it's recurrent HLH, then more clue would come in the domain of these autoinflammatory disorders. And of course, we will seek the help from rheumatologists to figure out that is this fitting the spectrum of autoinflammation? And if so, what further genetic testing or test we can do? So that would be my thinking as of now. Yusuf, what do you think?
I was just gonna say, if the listeners are thinking that they had no idea what Kirtan suggested in the end, I'm gonna say me too. So I always learn from Kirtan, and who's now an attending for the past 3 months. So thank you, attending Kirtan, for always teaching us so much. Back to you, Victoria.
Yeah, this case is definitely a zebra. I've never heard of NLRP3. That's super interesting. I do have some labs that I want to show you guys. Is it possible if maybe I could be made co-host just so I could share? Because I think it's so important for you guys just to see the trend of the labs.
Yeah, I made you co-host.
Okay. Okay, perfect. And you guys can see my screen, and I put the abnormal labs in red for you guys. So I did see him September 11, as I mentioned. The labs are from September 12, as you can see here, all the way up to September 17. what I think is really cool about this is we still see the bicytopenia. So just going over quickly the labs, we can see that the hematocrit has still been low and it's sort of uptrending a little bit. The platelets, again, they were still low, but again, with treatment, they were uptrending a little bit. The neutrophils were also low. The ferritin, I thought this number was really crazy. I talked to lab to ask, like, what does it mean greater than 33,000? And they said their machine can only detect up to this number. It can't detect any more higher. So really, the ferritin could have been even a lot higher than it is labeled here. But then it did start to downtrend on September 17 to this number right here. And the transaminitis, not as bad as it was when he did present to the ER, but you guys can see that it is still elevated. And I do want to talk about the imaging. So I'll just stop sharing my screen, just take a little mental snapshot of what those labs were. And I'll move forward to the imaging. We did do a MRI head, which was unremarkable, didn't find anything. They also did a CT chest, abdomen, pelvis. The only impression that they gave us was the spleen was enlarged and the liver was also slightly prominent in size, is what they had mentioned. They also noticed some small mediastinal lymph nodes that they identified, but otherwise they didn't see anything. And the spleen was really large. When I saw the CT scan, I wish I had a picture of it to show you guys, but it was like you could see it. And then I'll just take a quick pause here if you guys want to keep on talking.
Sure. Yusuf, you want to go first?
I'm not sure I have a lot to add diagnostically. I think, again, very tricky case. We see that the ferritin is like markedly elevated, and we're wondering about like HLH and where this has like progressed to HLH, like Kirtan was saying. And I think our job will be to rule out mimics and secondary triggers. So as we treat that, I think continue to look for triggers. I think one thing that stood out to me was the neutropenia. I did not expect that. I don't know, Kirtan, if you know more about that. Like, I did not expect the neutropenia to be this low. I thought maybe it recovered in the end, so I wasn't sure if it was persistently low. Do you know that, Victoria, or you're not sure?
I'm sorry, if the neutropenia was still consistently low?
Yeah.
It did start to uptrend. So it was 0.7,
Okay.
1.3, 0.5, and then September 17, it was finally 4.2. It was finally like getting back to normal.
That's helpful to know. Yeah. So again, usually with neutropenia, you want to think of, is that a susceptibility to infection or is that a product of the infection? So similar to what I was thinking earlier, it's like, could there be like a tick-borne illness or something on the smear that we're gonna look for? And other things that cause neutropenia, which I don't think we have here, but things like rheumatoid arthritis, for example, or like some forms of leukemia, but again, lower on my differential. Not a lot to add. I think in this aliquot, I think what I would do is one, run a smear, send some infectious workup, and in the parallel, talk to room and see what kind of immunosuppression they're considering and when the ideal time is. What are you thinking, Kirsan?
So no, Yusuf, I agree with you that ferritin is high and there are cytopenias. So of course, HLH is like the low-hanging fruit, but we want to maintain the due diligence and rule out the other possible causes. So far looks like that a patient has like normal coags and is maintaining well. So no concern for liver failure because sometimes acute liver failure can cause high ferritin and mimic HLH. So we need to rule that out. Second thing is sometimes people can have catastrophic antiphospholipid antibody syndrome, which is another known cause of hyperferritinemia. But in our case, we don't have any clear signal to APLS, and usually people with APLS are very sick and unstable. And I am sure that this person who has been seen by doctors multiple times, they would have checked ANA and APLS. It's like very common thing to rule out, right? So that part is out of the equation. Now the question becomes that once we have ruled out liver failure, APLS, then what can cause this much high ferritin? So it's again we come down to the HLH only because that's the simplest explanation for the liver damage, cytopenias, and fibrinogen being low also is very helpful because there are not many things which will cause fibrinogen low. Like DIC will do it, but you won't be in DIC for this long, right? So looks like that it is HLH. And now our job is to figure out what triggered the HLH, right? So for the infectious workup, as Yusuf said in the first aliquot, that although it is very unusual for infections to come with urticaria again and again, but at least making sure that all the intracellular organisms like HIV, herpes group of viruses, then tick-borne diseases like Ehrlichia, Anaplasma Lyme, all of that, all the endemic mycoses, these culture negative infections, we should rule them out to be on the safe side, right? Once we have gotten rid of the infections, then the two main things remain, that is this immune driven or is this neoplastic, right? Is it possible that this person has some kind of lymphoma in the body with organomegaly and with recurrent HLH? It is possible, but it would be unusual because in general, if lymphomas end up causing HLH, it will happen once. You will find the lymphoma, you either treat it or don't treat it, but it won't happen that you respond to some immunosuppression, then you come back again, right? So that would be unusual. But if we had to guess that what lymphomas can do this, almost any lymphoma can do this, but the big ones would be that could it be Hodgkin's? Hodgkin's can come in younger people like this. It can have myriad presentations, including the rash or not. So at least getting one of the lymph nodes to be biopsied if it is possible, or getting a tissue from the spleen or bone marrow would be important. Second is there are some T lymphomas. So one of the T lymphomas which we have learned from our CP solvers colleagues, right? Jeffrey has told us many times that there is angioimmunoblastic T cell lymphoma, which is known to mimic the autoimmune diseases. And since it's a lymphoma, it can end up causing HLH, right? So getting the flow cytometry of the blood, making sure we get the T cell rearrangement genes to make sure we are not missing any T cell lymphomas. And then there are rarer lymphomas, right? Like we have intravascular lymphomas, which could be missed on all the biopsy specimens until you get like the blood vessel biopsy, and maybe there are B cells infiltrating your blood vessels. And intravascular lymphoma is one of the well-known occult causes of recurrent HLH. So that would be something on back of my mind. And I will also do a very thorough skin examination elsewhere to not miss any other subtle rash. There are certain cutaneous lymphomas, like subcutaneous paniculitis like lymphomas, which can end up causing HLH, right? So I don't want to miss a hematological disorder which can cause HLH. Once we have moved past this, then now all which remains is rare, right? Like all the autoinflammatory disorders. So again, at top of my mind, I'm thinking that of more than 100 autoinflammatory disorders, which are like 3 or 4, which are known to cause HLH, and which also have urticaria as the overlap. So as I was alluding to earlier, that the most common bucket is this familial cold autoinflammatory syndrome. So I will see and I will ask rheumatologists that do you think it could be one of these 3 NLRP3 disorders? If we exhausted that, then we go to NLRC4, which is another inflammasome, which can also cause HLH. And usually they have some GI symptoms. So I will see if this patient eventually underwent colonoscopy to rule out any colitis component. Once we move past that, there are certain interferon stimulated genes like ISG10, like it's like there's no point in mentioning the name, but the thing is that there are some interferon related genes which can end up causing HLH. And then one case which has been on CPE solos before, like something known as AP-LED, which is like phospholipase C gamma associated antibody deficiency and autoinflammation. So that can also end up triggering HLH. Let's say if rheumatology comes and we send the genetic testing, it's negative. So now what? So once we have ruled out the secondary causes of HLH, now we come to the primary HLH, which is very rare, that you have mutations in the granules of your macrophages and NK cells, which are impairing the ability to release the granules, and that's why you have HLH. So usually, what are these genes? So the classic genes are mutations in perforin, granzymes, syntaxin binding protein, all the vesicular proteins, which can trigger the HLH. So I would ask the immunologist that do you think this person can have primary HLH from the mutation in vesicular protein or not? And another important aspect I wanted to mention is that so many of the autoinflammatory disorders can have a component of recurrent infections. In our case, we have not heard a single infection which this patient has had, like recurrent respiratory tract infections, recurrent GI infections, cutaneous infection, which is an important clue because that steers us away from certain inborn errors of immunity, which can come with immunodeficiency and inflammation. So my mind currently is in the autoinflammation and primary HLH. What do you think, Yusuf? That any other like caveats that you have in mind?
I think to summarize, the helpful teaching point here is that HLH is a unique form of inflammation. So like if you see lymphocytosis, you immediately think of specific diagnoses like HTLV. And similarly, if you see HLH, you should think of specific etiology, so a special form of inflammation. So this is where you want to consider intracellular organisms. I think this is the teaching point I would take here, like EBV, CMV, herpes, etc. So you always want to think of these. Tuberculosis is a common one, histo, and then after you rule out the common things and malignancies, then you can move on to primary. And I think the issue of time here, the subacute onset to chronic, makes you wonder about like primary disease and with a and with like a hidden infection somewhere that you might want to rule out. That's where I'm at. And can't wait to hear more, Victoria. How many aliquots do we have left?
Actually, I only have one left with the actual diagnosis. So you guys let me
Oh,
know if you want if you want the answer.
okay. I think we're gonna pause here for 2 minutes, have people discuss in breakout rooms, and then we'll come back. And the question from the breakout room is, what are your top 2 diagnoses? What do you think this is gonna be? And once you come back, you can put it in the chat. Welcome back, everyone. Kirtan, any final thoughts? What are your thinking this is? If you had a guess, what would you say it is?
No, first let me ask you, Yusuf, because I want to pick your brain before I commit.
Yeah. Just the same question.
Yes.
I think the same question is like, I don't know. I'm not like confident. I think what I know, what I would do next is at least I would rule out the infectious mimics just to feel more confident about giving a higher dose of immune suppression. So I think like a smear, serologic testing, antigen testing, I think I would do that. And I don't think I've ever seen like an autoinflammatory disorder in real life. But I think what I know is that I want to rule out the mimics, so get an LDH, see if there's like room for a skin biopsy, and then take it from there. What are you thinking, Kirtan?
Yeah, I am also same level as you that like although it's like hard to fathom that what infection you missed for like over like 1 year or so, which comes intercurrently, but at least taking care of all the infection is wise. The second thing is that lymphomas, like I don't see any like large lymphadenopathy which they could biopsy, but I guess at least skin biopsy, random, or the bone marrow biopsy to rule out those lymphomas. And then again to the square one, right? We need to ask the rheumatology if they think this could be one of the innate immune system gene mediated. So like if I had to guess, I would say that either it's NLRP, NLRC, I would get immunoglobulin levels to make sure it's not like autoimmune lymphoproliferative syndrome, which can sometimes do this. And you can fix it by giving someone IVIG, like simple fix, right? So, but again, the issue is that all these will cause infections. So that's why I'm thinking that could it be lymphoproliferative syndrome? Probably not. And then there are other rare disorders, like there is something known as neonatal onset cytopenias, rash, and HLH. But those rashes are different than the rash which we have, and they come at very young age. So even the age is a little bit atypical for those autoinflammatory disorders. So only the adult onset inflammatory disorders which remain are like this, the NLR stuff and the phospholipase C stuff. So I guess it could be one of them. And if not, then go for primary HLH, the vesicular protein. So yeah, that would be my approach. And let's see, somebody said in the chat if what they were thinking. Yeah, Schnitzler, good thought, Andrew. Yeah, that's why we wanted the paraproteins and bone scan. All right, friends, share the final thoughts. We are near to the end. We need to get the answer.
Should I go? Okay. So yes, the answer was HLH, otherwise known as hemophagocytic lymphohistiocytosis. And when the patient arrived to the ED, they actually had done a bone marrow biopsy, and it did come back. I'll just read to you what it said. It said markedly hypercellular with prominent hemophagocytosis, consistent with hemophagocytic lymphohistiocytosis, which is HLH, in the appropriate clinical context of fever, cytopenias, hyperferritinemia, hypertriglyceridemia. I don't have the triglycerides. I'm sure they took it. I'm just not sure why I didn't jot it down. And so, yeah, that was the answer. They were thinking that it could have been precipitated by his CMV positive, and so they were just going to continue to monitor those levels. They also were going to order genetic testing for familial HLH and also X-linked hyper IgM due to a possible genetic predisposition that maybe could have been suppressed while he was on the biologics and on the steroids. And the way really to treat it is, as you guys mentioned, you do have to control the hyperinflammation, right? You have this cytokine storm, but then you also have to treat the underlying trigger, which is they're trying to figure out like what was the trigger. But the therapy that they used was anakinra, which is also a biologic. It targets IL-1. They started it at 400 milligrams, and then when he was discharged home, they tapered it down to 200 milligrams for it to be sub-Q twice a day, as well as a 60 milligram dose of prednisone with tapered dosing. What I found interesting was because he is on all of these immunosuppressants, you do have to give PCP prophylaxis. And usually I've seen people receive Bactrim, which is otherwise known as TMX SMP. But my attending said that they actually prefer to use atovaquone because of his transaminitis. I'm assuming that with the TMX, that could cause some liver damage. And so instead of using the usual Bactrim, they used atovaquone. And then we were just going to continue trending his CBC, his CMPs, continue trending the labs. As you saw, the ferritin was decreasing. And then I was off the service, and I'm sure he went home to his family.
Wow, thank you so much, Victoria. That was awesome case. Any reflections, Kirtan?
Oh no, I'm like very amazed by how you presented. This is your first time and you presented very like thoroughly, comprehensively, and like so much data upfront itself that there was nothing else remained to discuss rather than the rare things. So it was so fun. And hopefully maybe later down the line, if you come to know if they did the genetic testing, maybe you can update us. That would be interesting to know because like that's how things progress, right? That people get diagnosed of HLH and then all the game is about finding the trigger so it doesn't happen again.
Yeah, I would love to. If I ever go back to Hackensack, I'll be sure to do that. And maybe I'll just send you guys an email. Like, this was the update for this cool case.
Yes, perfect.
No, that was amazing, Victoria. Thank you so much. And please keep joining us for any case, even it doesn't have to be a zebra. Zach E., the floor is yours.
Thank you so much, Youssef and Kirtan, for an amazing discussion, and thank you, Victoria, for presenting in such a masterful manner. Quite a complicated case and a lot of teaching, and I won't do justice to the teaching that Kirtan and Youssef have taught us. But just in brief, we started off with a young gentleman who had the diagnosis of Still's disease, which we know is an autoinflammatory disease, which usually presents with this sort of background of arthralgias, fevers, and the classic salmon rash. And the treatment is essentially biologics, as with all other autoinflammatory disorders. And we must note importantly that Still's disease is a diagnosis of exclusion. So we must importantly exclude, first of all, infections, malignancy, and then other autoimmune disorders. And what was atypical in this case with Still's disease is usually monophasic, as opposed to other autoinflammatory disorders, which are usually cyclical. And then some clues that clue us into this case of or the diagnosis of HLH is when we think and we see a high ferritin and cytopenias, we should think of HLH. But importantly, we should look at whether this is primary HLH or secondary HLH. And in most of the cases, it's secondary. So you should look for the trigger, which can be common viruses such as CMV, EBV, other bacteria, malignancy, and other autoimmune disorders. And also we must include, as Youssef mentioned, importantly, mimics of HLH, and we must systematically exclude other causes. First of all, infective, then autoimmune, which can respond to a trial of immunosuppression, and then look for other triggers like hematological malignancies. Kirtan also mentioned a lot of other esoteric causes like familial cold, autoinflammatory disorders, and many others. And then also important pearl that Youssef mentioned earlier on was that patients on biologics, it's important to monitor them, concerns for infections in general, but specifically that of intracellular organisms. And then when regards to approaching relapsing fevers, infective causes, there's less chance or less likelihood of catching them on a positive blood culture. So rather we should look for hidden clues when trying to identify these atypical infections. And we should look for clues in the lungs, on the smear, some we can pick them up on serology. And then Youssef and Kirtan both brought up the doxy deficiency schema, which is available on the CPS website. It's also a similar kind of triad. And then Kirtan also importantly mentioned that when we see a patient with some kind of liver involvement and fevers, it's also quite important to exclude zoonotic infections. And then we went through some of the autoinflammatory disorders, and they primarily defects in the innate immune system, as opposed to the classical autoimmune disorders, which are disorders of generally like the B and T lymphocytes. And then when we deal with the esoteria of your urticaria and arthralgia, there are some common things which come to mind, such as, or not so common, but common to Kirtan, such as systemic mastocytosis, Schnitzler syndrome, and NLRP3 mediated disorders. A lot of reading for us to do. And again, some common causes of a high ferritin, think of HLH, catastrophic autoimmune, catastrophic antiphospholipid syndrome, liver failure, many other causes. And then again, back to HLH. After excluding systematically secondary causes, we can then consider primary HLH, and there's many associated genes with HLH. And then essentially, the treatment of HLH is high doses of immunosuppression and, of course, treating the trigger. Thanks all for the great case. And
Thank
watch
you,
the recording
Zach.
again. A lot of reading to do.
Thank you so much, Zach. That was really, really awesome. If anyone is watching and wants to present a case, it's super easy to sign up. You can go on the website and just hit morning report. And after that, you can just click on present a case, and someone from the team will reach out and help you organize the case and schedule it. It's super easy, and the case doesn't have to be like a super rare case. It can just be anything common. We love discussing, we love learning, always learning from Kirtan every day. Victoria, looking forward to seeing you in the future. I hope you all have a wonderful Friday.
Thank you so much. Appreciate it.